Alright you guys, welcome back to another video lesson from ICU Advantage. And in today's lesson, we're going to be talking about something that has really come into almost mainstream practice when dealing with COVID-19 in these patients. And that is specifically in talking about prone positioning. Now, it's certainly not something new, it's definitely been around for a while, but with everything that's happened with COVID-19, we've really found this therapy to be quite effective for these patients, and we're really using it a lot nowadays. And so because of that, I really wanted to do a lesson talking about this and give you guys some more information on how it is that prone positioning actually is helping our patients, and then just going over some general good tips and good information to have when you are proning your patients. And so again, make sure and stay tuned. I've got a lot of really good information in this lesson for you guys. But if this is your first time to this channel and you'd be interested in more of these critical care educational content videos, then I really invite you to subscribe to the channel below. When you do, make sure you hit that bell icon and select all notifications. That way you'll never miss out when I release a new lesson. And a shout out to all you awesome subscribers out there who continue to come back and watch these lessons, like the videos, leave comments. I love reading your comments and responding to you guys. And a special shout out and thank you to our loyal Patreon subscribers. You guys have access to additional information and content that you can't get just here on YouTube. So a really big thank you to you guys and really to everybody who watches this channel. And so with that said, let's go ahead and jump on in. But for those of you who don't know me, my name is Eddie Watson, and this is ICU Advantage. Alright you guys, so the first thing that I want to talk about here with you is really to go over what exactly is proning and why is it that we do it. So when it comes to proning, it really is simply a matter of taking patients who we normally have lying supine and flipping them over onto their stomach into what we call the prone position. Now this is something that we can either do manually with our patients and flipping them in the bed that they're in, or we can also do this with some sort of specialized bed such as the rotoprone bed, which if you guys have never seen this bed is pretty amazing in what it can do. Now in the past, at least where I work, if we needed to prone somebody, for one it was usually a salvage therapy that we were doing. We were pretty far along into their illness. But when we did it, we almost exclusively did it with one of these rotoprone beds, which again, it's pretty amazing. You put the patient in there, you strap them in, they kind of get secured nicely into that bed, and the bed automatically flips them over and actually will rotate them back and forth. And it makes it really easy to prone and supine these patients. Now, prone positioning has actually been around since the 1970s to treat patients with hypoxia, but nowadays we're proning patients with what we call acute respiratory distress syndrome, or ARDS, with the goal of improving their oxygenation and gas exchange. Now, many randomized controlled trials have been performed looking at the benefits of prone positioning. The most recent of these is the one that we call the PROSEVA study. And this one was published in the New England Journal of Medicine in 2013, and it was actually looking at 466 patients with severe ARDS. So these were going to be patients with a P to F ratio, which is basically that ratio that compares our PaO2 to our FiO2. They had a P to F ratio of less than 150, and they were proned early, and this showed a significant improvement in their condition. Now what we saw were both 28-day and 90-day mortality benefits, and for our 28-day mortality, we saw 16% versus 33% in the non-proning group, and with our 90-day mortality, we saw 21% versus 41% in the non-proning group. So as you can see here, just clearly significant advantage to proning these patients early. Along with the mortality benefit, we did also see improvement in ventilator-free days in both the 28-day and 90-day group. And the reason this is important here is because the SARS-CoV-2 virus can cause a viral pneumonia in patients, something that we call COVID-19. And we're seeing numbers somewhere up to 17% of these patients are believed to develop some degree of ARDS. So as a result, we're seeing a lot of patients with ARDS as a direct result of COVID-19, and one of the great therapies that we discovered for that is proning. So now real quickly, I want to cover what is ARDS. What is ARDS? Now, this is going to be a really quick overview, as I am going to dedicate a future lesson to going over all of this stuff in much more detail. But essentially, ARDS is an acute diffuse inflammatory lung injury. And along with this, we see increased vascular permeability, increased lung weight, and really loss of aerated lung tissue. And as a result, we end up seeing increased physiological dead space, which if you remember is going to be where we have perfusion without that ventilation, as well as decreased lung compliance. Although in COVID-19, we really aren't seeing as much of the decreased lung compliance that we're really used to seeing typically in ARDS. So now let's actually talk about what's happening in ARDS. And here I drew a real simple picture of an alveoli and a capillary. Now, as you remember from anatomy and physiology, we have 300 to 500 million of these alveoli. Quick little plug, if you don't remember that, I'm going to link to a lesson up above where I did a really good overview of the respiratory system. Now, for simplicity here, I just drew the one alveoli with the one capillary, but in reality, the alveoli is surrounded by capillaries. And so here in the alveoli, this is where we have air coming in. This is going to be our V for ventilation. And then through here is where we're going to have our blood flow, which is going to be Q, or our perfusion. Now, what happens when the SARS-CoV-2 comes down in here and infects the lung tissue is that that's going to lead to an immune response and ultimately inflammation. Now, as I talked about, this is going to lead to that capillary permeability, and this is going to cause fluid to build up in this space around the alveoli, in addition into the space between the capillary and the alveoli, making it more difficult, more distance for that gas exchange to have to take place across that bigger area. Now, in addition to that, inside the alveoli, we're going to see edema and purulent material build up inside of there, decreasing the surface area for the available gas exchange to take place. Now, again, in the case of ARDS, this is happening throughout the lung, affecting almost all areas of lung tissue. And as you can imagine, that's going to really cause some problems for our patients. Now, I think we've all seen the telltale signs of the whited out lung on chest x-ray. Here I'm going to show you an example of what a healthy lung looks like. And if you remember, the black is air. So as we can see here, we've got a well-ventilated lung throughout all the lung fields. Now here, these are two different examples of actual COVID patients in ARDS and what their chest x-rays look like. And here we've got that real telltale sign, whited out lungs. And here white signifies denser material. So instead of the black representing air, we're seeing fluid throughout the lungs, really causing problems for these patients. As you can see on one of them, we do have an ET tube, so clearly this one has gotten pretty severe. Now, speaking of severity, let's actually talk about our ARDS severity scale. And it's pretty simple. There's really just three severities, what we call mild, moderate, and severe. And in our mild cases, we're going to classify this if we have a P to F ratio anywhere from 200 to 300. For moderate, they're going to have a P to F ratio of 100 to 200. And we really consider severe to have a PF ratio less than 100. All right, so that was our really quick 10,000 foot view of ARDS and what that is. So let's actually get into the meat and potatoes of what we want to talk about here, and that is, how does prone actually help our patients? Now, when we're looking at the ways in which proning is going to help these patients, there's three primary big overarching categories on why this is beneficial to them, and that's going to be by improving alveolar ventilation, improving VQ matching, and other physiological benefits. So I've actually got a lot to cover here, so let's start off and talk about this first one here, improving alveolar ventilation. So as I already discussed with you guys, edema is a big problem in the lungs with ARDS. Now our lung tissue can be kind of porous, and if you almost kind of think of like a sponge-like material, and therefore we have fluid that's going to tend to be pulled in the direction of gravity. Now in our typical ICU patients, this means the fluid is going to be more prone to move towards the dorsal or the backside of our patient's lungs. And this can really impact our patients in several different ways. First, though, we need to understand about the shape of our lungs. Now, our lungs are not evenly shaped, and in fact, they kind of have this conical shape due to the space of the thoracic cavity that they're in. Now, I'm going to draw an example here, and this is by no means entirely accurate, but it's really going to help to drive some points that I'm trying to make here. This is a really simplistic essence of the shape of our lung. Now, there's a few things that are going to be happening here. We're going to have pressure from the lung tissue itself, which, as we talked about in ARDS, we have this heavier lung tissue from the fluid, and this pressure is going to weigh down on itself, and the dependent section of the lung is going to become compressed. And this is actually going to be compressing alveoli. So if you kind of think about it, we have our normal-sized alveoli up top here. But then as we start getting towards the bottom, because of this pressure and compression, we're going to see these more compressed alveoli. And this is going to make it to where we have less surface area available for gas exchange. We also have the additional edema in the lungs, which, like I said, this weight and pressure is going to be increased, pushing down, compressing those alveoli. Now, due to the shape of the lung, we're going to have fewer alveoli in the lung on that ventral or front side, so over here, and we're going to have fewer of these alveoli that are actually remaining open, while we have many more alveoli on the dorsal side or the back side that are going to be compressed and have less availability for gas exchange. Now also, again, due to gravity, we know that more fluid is going to be building up in those dependent lung areas and ultimately those alveoli. So this means in addition to that decreased ventilation from the pressure of the lung tissue, we're going to have alveoli with really less ability to aid in gas exchange. Now, in addition to that, we also have something that we call shape matching that's going to take place in the lung tissue, conforming to the shape of the chest wall. So again, let me draw a couple quick examples here. And to understand what I'm talking about with shape matching, it might help to think of this in sort of like a slinky analogy. Now, the lung is attached and held to the thoracic cavity thanks to the surrounding pleura. But because of the weight of the lung, it's going to pull down due to gravity, causing stretching up top and compression down below. And so really you can think about that slinky where if you hold it on one end, it stretches out and then gets more compressed down at the bottom. And this stretching of the lung tissue actually leads to larger alveoli up in the ventral section of the lung with this residual capacity, and then again, smaller and compressed alveoli on the dorsal side of the lung. All right, so what happens then when we actually prone our patients? What happens is we're actually going to flip this entire physiology. And so now, instead of this pressure building up on the greater number of alveoli, we're now putting pressure on a smaller number of alveoli available on that ventral side. And so when we look at the compression of those alveoli, here on the dorsal side, we're going to have the alveoli open and available for gas exchange, and then in a much smaller segment down below, partially due to the curving shape of the thoracic cavity, but we're going to see less of these alveoli and in smaller numbers being compressed down at the bottom. Now again, also due to that slinky effect that I talked about with the shape matching, when we're in the prone positioning, there's really less area for the lung to kind of hang down into, and so this leads to a much more evenly sized alveoli and less compression because, again, there's not that space for that lung to go down into. So we really kind of see a much more even distribution of lung tissue, and as a result, a more evenly distributed size of alveoli. And once again, as we know, the fluid is going to move with gravity, so we're going to end up with fluid being accumulated down here in the bottom, or in this case now the ventral side of the lung tissue, where we have less alveoli and less problems that this fluid can cause. Now, to really drive all this point home, I really think that an image of a CT scan that I found really makes the point of what I'm talking about here. Now, here on the top, we have a patient who is in supine position, and down below, we have a patient who is in prone position. And as you can see, when we're in the supine position here, notice this accumulation of density and fluid building up on that dorsal side. And as we just talked about, this is the area with more alveoli available. Really, we just had this tiny area here on this image with good ventilation taking place. But now if you look down below in this patient who's been prone, we have to actually flip the view here, and we're looking at these lungs on opposite sides. But now we've got that density and fluid building up on that ventral side, and now we can see much better ventilation where on this side before we hardly had anything, and even more significantly over on this side here with a much larger area that's currently being ventilated. Again, we know we have more alveoli here, so by flipping them prone, we're opening up so much more of that lung to be available for gas exchange. So like I said, I really just think that this image just really drives home the point of what we're wanting to see when we prone these patients. All right, so that was improving our alveolar ventilation. Now let's talk about number 2, which is going to be improving our VQ matching. So now you're probably like, Eddie, I remember hearing about VQ, but what the heck is that? Well, in addition to the improvements that we see in alveolar ventilation, we're also going to see better matching of what we call ventilation and perfusion, something that we call VQ. Now again, V is for ventilation, which is essentially the air into our lungs, and Q is going to be our perfusion, which is going to be the blood supply to the lungs. Now ideally, we want to have these in a 1-to-1 ratio, basically meaning that we don't have a greater amount of one over the other. And when we do, this is when we refer to something called a VQ mismatch. Now, as we just discussed, when our patients are supine, we're decreasing that ventilation due to all those factors that we just talked about, and this is going to be causing a mismatch. In addition to that, though, we need to also understand about perfusion of lung tissue. So it used to be believed that perfusion was equal throughout the lungs. We now know that we actually have better perfusion and larger vessels on the dorsal side of the lung. And more importantly, is that studies have shown that this actually holds true whether we're supine or prone. And so because of this better perfusion on the dorsal side, when our patients are supine with the previously mentioned factors, we're decreasing the alveolar ventilation to alveoli that have the better perfusion, and we have less perfusion going to the ventral lung, which actually has the better ventilation, but not much of it. So again, this continues to cause mismatch in our ventilation and perfusion. And so our goal is to best ventilate the area with the most perfusion, but in our supine case, the opposite is actually happening here. So here, when we prone our patients down below, we're going to have better ventilation going to the dorsal lung with more alveoli that also has the better perfusion. We create less of a mismatch, which is ultimately going to help improve oxygenation and CO2 clearance. So hopefully that makes sense. We've now talked about the improved ventilation that we're going to get. We're going to talk about the improved VQ matching by matching up the ventilation with the areas of greater perfusion. So now let's last talk about some of these other physiological benefits that we see. So for starters, we're going to see improved hemodynamics. So we're going to see an increase in both our right and left heart preload. So respectively our CVP and either our pulmonary capillary wedge pressure, or pulmonary artery occlusive pressure, whatever you want to call that. But we're also going to see a reduction of right and left-sided afterload. So here we can think a decrease in our pulmonary artery pressure, or pulmonary vascular resistance, and our systemic vascular resistance. Now, if I lost you with this a little bit, I'm going to actually link up above to a series that I did on hemodynamics and cardiac output that I think will really help to give you a good understanding of what I'm talking about here. But to go along with these improved hemodynamics, we're going to have less compression of the lung tissue, making it easier for the right ventricle to perfuse the lung tissue. So again, this increased perfusion is only going to help to improve our VQ matching like we just talked about, but it's also going to help to stave off and prevent right heart dilation and failure, which sometimes can be a result of ARDS and having this increased pressure required to perfuse the lungs. So there's less resistance for that right ventricle to pump against, but there's also less compression and less resistance, making it easier for blood to return to the left atrium. Thus, that's how we see that increasing left-sided preload. All right, so next I'm actually going to talk about cardiac and abdominal organ pressure on the lungs. And to do that, I'm actually going to draw two patients. I'm going to do my best here, but one with a patient who is supine and another looking sideways into our patient who is lying prone. So sorry, not the greatest of drawings here, but basically this here is going to be our patient's buttocks, meaning that this is our dorsal side, and then this is going to be our ventral side on both of these drawings. So essentially we have our supine here and our prone here. And in here, let's go ahead and draw our lungs. And the first thing I want to talk about is our heart. So here in our supine patient, we're actually going to have, due to gravity, the weight of the heart pushing down and compressing, adding pressure to that lung tissue on the dorsal side. But in the case of our prone patient over here, we actually have the heart that's going to be resting on the sternum and not putting pressure and really compressing the lungs. Now, in addition to the pressure of the heart, we know that we have our diaphragm, which sits here. And because of the shape and when our patients are lying supine, we're going to have the pressure of the abdominal organs, which are also going to be putting pressure on part of that dorsal side of the lung. But as you can see, when our patients are prone, because of that shape, we're not actually going to be getting that pressure of the abdominal organs on that dorsal side of the lung. Again, one less thing adding on to compress the lung tissue. Now, finally, two last little points that I do want to make. One is that we actually see better secretion clearance when our patients are lying prone as opposed to supine. It's just a little bit easier for those secretions to work their way out. And secondly, due to the increased lung compliance, because we're not as compressed and we have decreased pleural pressure happening, that this is going to not only help reduce the PEEP requirements, but again, we're improving compliance, which means we're going to help to reduce barotrauma injury. Whew, all right, look at that. Wow, a lot of really good information. We covered a whole gamut of different reasons on why putting our patients in a prone position is going to be beneficial for them. So yeah, heck, seems like a lot of really good reasons to be doing this. But as always, there are risks that are associated with proning people. Now, fortunately, a lot of the risks I'm going to talk about here are things that are preventable. But the main risks that we're seeing issues with patients who are being prone are going to be things like pressure injuries, airway occlusion, and this is going to be due to that increased secretion mobilization. We also run the risk of a lost airway, aka tube dislodgement, as well as we run the risk of lost lines and tubes as a result. Now, the two at the very top here are pressure injuries and our airway occlusion. These are the two biggest and the most common that we see. But again, just about all of these can really be prevented in proper monitoring and maintenance with our patients. All right, and so lastly, I just wanted to go over some useful information when you're proning your patients. Now, when talking about proning, the longer we prone people, the better the outcomes. The greatest benefit from this comes from at least 12 hours of prone positioning per day. We still want to reverse Trendelenburg the bed to keep the patient's head elevated. And really early on, our patients may not tolerate supine after they've been prone. And we can see this both in decreased oxygenation as well as just hemodynamic instability. Now, to go along with all this, we may require additional sedation and possibly the use of a paralytic in our patients. Now, obviously, both increased sedation and the use of paralytics come with their own risks and downsides, aka delirium and atrophy. Now, we really consider having a PF ratio less than 150, that really the standard of care is to prone these patients. But we're also seeing that early awake proning is actually showing benefit in our patients. And so this is where you go in and someone who is with it is able to just roll over on their belly with lower amounts of oxygen requirements than, let's say, being vented. And this is showing benefits and improving outcomes in these patients. So definitely something you want to be on the lookout for and potentially seeing the use in your practice. Now, again, I talked about one of the risks being pressure injury. So one thing that's really important is our pressure injury prophylaxis. And here you want to use things like an Alveolar or other pressure-reducing pads, and we want to place these on the bony areas like elbows, knees, hips, the chest, and even the forehead. As well as we also want to make sure and move the ECG leads to the back, because if we leave them on the front, that this can also cause pressure injuries. Now, another really vital thing to have when you're dealing with these patients is actually having a prone team. Now, obviously, having a dedicated prone team is going to be ideal because it's going to decrease the workload of the people that are actually working and caring for these patients. We're obviously proning many of these patients, and it takes a lot of time to prone and do the Q2-hour position changes, so having that dedicated team, if it's available, is really a game changer. Now, regardless, though, we still want to have a team. We want to have at least 4 to 5 people to assist with the proning and the position changes. You should have a respiratory therapist at the head of the bed watching and protecting that ET tube. We also want to be preventing circuit disconnects and possible aerosolization. One interesting thing that I did see is some hospitals will actually clamp the ET tube trying to prevent the issue of aerosolization. Now, along with this, you also want to dedicate someone to watching the lines, tubes, and pumps. Make sure that you have the vitals and the vent screen, that you can see it at all times, and that you have somebody that's monitoring that. And the big takeaway here is going to be that communication is key. I mean, it really sounds so cliche to say that, but we really have to work together as a team to ensure that everything is done in a smooth manner. Now, some of the things to think about as a pre-prone checklist, and this is going to be by far not an all-inclusive list, but just some things to get you thinking about are, do you need an ABG beforehand? Make sure you do eye and oral care prior to proning. Make sure you're suctioning both the ET tube and oral secretions. You want to stop any non-essential infusions. Ensure that all your lines have adequate length and that they're protected. Make sure that your ET tube is secure. And on that note, make sure that you have supplies nearby in case there is a tube dislodgement and you need to re-intubate or correct the tube positioning. Ensure that you have adequate sedation in your patient. Arrange things like your chest tubes and your Foleys to be down at the bottom of the bed, as well as stop any NG tube feeding. So again, not an all-inclusive list. I'm sure you guys can think of additional things on here, but just some things to get you thinking about to prepare yourself for a successful proning of your patient. Now, when it comes to actually proning your patient, there are some really nice techniques that we can use. Now, there's some really good videos out there that can show you guys how to actually do this, but it's something that we affectionately have referred to as the burrito method. So essentially, you've got your patient here lying in bed supine, and we know they're already under a white sheet, but what we want to do is place a second white sheet over them, and you want to roll up these edges until they're right next to the patient here. And this is basically going to be securing the patient in the sheets. And this is going to give you easy to grab handles to hold on as you turn the patient. Now, once you have them wrapped up, you want to slide them over to the side of the bed, roll them over onto their side, slide them back over more if you need to, before finally rolling them all the way to their stomach. Again, like I talked about, communication and timing is key. You want to designate one person to be the lead that's calling out the commands and countdowns for when we're doing them. Now, once you have your patient flipped over, we need to ensure that we have the proper positioning. And this is going to be something, again, that we've affectionately referred to as the swimmer. And the reason we call it this is because it really is some of the same mechanics that you would be using when you're swimming. So here again, we have our patient lying in bed. And what we want to do is we want to have one side where our leg is straight and our arm is straight down at their side. Then we want to turn their head in the opposite direction. Then we want to place pillows underneath our patient. And on the opposite side, we want to bend that one leg up, as well as bend their one arm up above, almost like they're swimming. And then just like we do when our patients are supine, every 2 hours, we want to flip them and then flip them and continue to do this every 2 hours, flipping the opposite side, turning their head the opposite way, bringing the one arm and one leg down, raising the one arm and the one leg up every 2 hours. And finally, the last thing to remember here is don't forget about our foot drop prophylaxis. All right, well, hopefully you found some of that useful information helpful, gave you guys some things to think about, and really overall, I hope that this entire lesson was beneficial in helping you to understand what's happening with proning our patients, why is it that it's beneficial, what's going on, why is this such a good thing for them. So I hope you guys enjoyed this lesson. If you did, make sure and leave this video a like. It really goes a long way to help support this channel. Subscribe to the channel if you haven't already. And if you're really looking for extra ways of showing support, then head on over to the Patreon page and take a look at some of the extra perks that are available over there. Make sure and keep an eye out for when I release the next lesson, but in the meantime, here's a couple really awesome videos for you guys to watch until then. As always, thank you guys so much for watching. Have a great day.